the proceedings in 3 minutes. By that time, kindly assemble yourself. Thank you very much.
In it, so it is MR1 first dose, then typhoid vaccine. This is also a new introduction, just 3 years ago it was added, and then IPV second dose. Then the next vaccine is at the 15 months, and it is the measles rubella second dose. And then we have a booster for DPT, which is diphtheria, pertussis and tetanus, which is given at 18 months. This is also an additional vaccine which is given only in Punjab and not in other provinces. So in other provinces, the child phases out of the immunization program at 15 months, and in Punjab, they phase out at 18 months. So this is the overall situation of Punjab. So you know about the population. We have around 120 million according to the latest census. So around 35 lakh children are born, 3.5 million children are born annually in Punjab alone. So all of these children are vaccinated by the immunization program, and currently the coverage is 90%. 90% means that 90% of these 3.5 million children are vaccinated for all vaccines. But if we look at individual antigens, the coverage is higher. For example, for BCG, the coverage is almost 99%. So every child born in Punjab gets BCG vaccine. And how this is provided, it is through 4,500 vaccinators across the province, then 3,000 fixed sites which include primary centers as well as tertiary hospitals, and also 45,000 lady health workers. So this is a huge network of service delivery staff which provides vaccines to children at the doorstep and at the health facility level as well. So as I was mentioning, this is the immunization coverage. So if we look at Punjab, according to the study by Aga Khan University, Imtiaz Saab will talk more about it as well. So in that, the immunization coverage in Punjab is 89%. This is for all antigens. So the antigens which we saw previously. When all of these are delivered, we call the child as a fully immunized child. So the fully immunized child coverage in Punjab is 89%, and in Sindh it is 68, KP it is 61, and Balochistan it is 38. And in Punjab, if we look at the improvement over the last 8 years, so in 2014, the immunization coverage was 49. So it has almost doubled in the last 8 years. And how it has doubled, it is through the electronic monitoring of the staff. So I'll show you how we are doing that as well. Because in other provinces, and even in Punjab before 2014, the problem was that they were just entering reports on paper and not actually going to field and not delivering the vaccine to the children, and just reporting it and destroying the vaccine. So when we started e-monitoring, every vaccinator is tracked through GIS, and we know that he is actually present in the field. So that's how the immunization coverage has improved. And this is the percentage of zero-dose children. So zero-dose children are those children who don't get any vaccine at all. It is exactly the opposite of fully immunized. So fully immunized means that the child gets every vaccine. Zero-dose means that the child did not get any vaccine at all. So if we look at the number of children who do not get any vaccine in Punjab, it is 0.9%, and in Balochistan it is 39%. So in Punjab, out of the 3.5 million births which I mentioned previously, only 0.9% are those who don't get any vaccine at all. So it means that 99% of our children are accessing the vaccine at least once in their lifetime. So the problem is not that we cannot reach them or they cannot reach us. So the problems for dropout, for not being fully immunized, are different, and those are related to side effects of the vaccine, or as the child grows up, the parents also become more reluctant and they don't as vigilantly vaccinate their child as they do for the newborn. And in Punjab, despite that fact that we have an 89% coverage, which is really good, but still our aim is to go up to 99%. And the reason why our coverage is low is, if you can look at this slide, so Lahore is the lowest covered in immunization. And this is shocking for many people, because Lahore, we consider that there are more health services, there are better health services, there are more hospitals, people are more educated, more richer than the other cities, but still the vaccination coverage is low. So the reason is that in urban cities there are slums as well, and the slums are not covered at all. There are no health facilities, there are no health workers in those areas, and they are most neglected and most vulnerable people. And because we are considering that Lahore is a good city, so no one pays as much attention as we do to other cities like Rajanpur, DG Khan, South Punjab and all those. So the coverage automatically goes better there. And so if you look at Lahore, Gujranwala and Faisalabad and even Rawalpindi, so they are quite less in coverage. So looking at this, if we look at a bit more in detail for Lahore, so in Lahore the zero dose percentage is 3.5%. In Punjab overall it is 0.9, but for Lahore it is 3.5%, so it is quite high. So we took a special initiative for Lahore, in which what we did was that we vaccinated over around 700,000 children in the last 6 months. And out of these, 122,000 have been fully immunized. So how this was done, that I will explain in a few minutes. If you look at the improvement, this is globally recognized improvement. It has been recognized by international organizations as well. Aga Khan did an independent study on this, and now the Global Alliance for Vaccine and Immunization, they are also taking it up, that how we improved in such a quick time. So if we look at Bangladesh, this much improvement was not seen in 4 years. In India, in Delhi, it is also an urban city, so they improved just 7% in 4 years, while in Lahore we improved 16% in just 6 months. So this is a big achievement, and how we achieved it, it was through this use of IT and also the use of polio workers. So polio workers are going across every community in the slums and as well as in the rural areas. So we use them to map and identify the unimmunized children. And once they identified them, the data of every child was entered in a software. So that it was the name of the parent, their ID card if available, their mobile number if available, and their address. And all this data was electronically recorded and then shared with the vaccinators. And the vaccinators were then tracked that whether they went in that area and immunized the child or not. So we covered around 2 million households in Lahore. And out of those, around 339,000 children were identified, 192,000 were immunized, and 8,000 zero-dose children were also immunized during this campaign. So if you look at this, I just explained that we are tracking through the electronic medical record system. So, excuse me. Every child data was entered in the polio dashboard. From there, it was shifted to the immunization dashboard, and it was sent to the vaccinators, and then the vaccinators were tracked through this polygon coverage. So if you look at this number 3, this one, so you can see that we had mapped every point on the Google Maps, and it was then used to track whether the vaccinator went there or not. And within the first 2 weeks, we had vaccinated 75,000 children. And looking at the success in Lahore, we are now scaling it up across the province, and wherever this polio campaign is done, we do similar mapping, and in the recent campaign, it was done in 8 districts, and the follow-ups are still ongoing. So we are now looking at Aga Khan again to do another assessment for us in the next year, so we can see how much improvement is there in the other districts as well. Besides for urban vaccination, this was the thing, and then the other which we are doing is to improve coverage, not just in Lahore but across the province, that the immunization services are now functional in the evening shift as well. So all the hospitals which are functioning round the clock, like teaching hospital, they are all functioning round the clock, the district headquarters, the tehsil headquarters, RSCs, and even the basic health units which are providing obstetric services round the clock. So they are now providing vaccination service as well. It is available round the clock, but public is not so much aware, so they are just coming in the evening shift at the moment. And the other initiative is about the birth dose. So it is now mandatory that any child who is born in any public sector health facility in Punjab, he or she has to be vaccinated for hepatitis B, BCG, and OPV0 before discharge from the labor room. So we are now tracking it. We are facing some challenges in this, not in the primary level, but at the teaching hospitals. So the reason is that in teaching hospitals, there is a big influx of patients. There are 40 deliveries, 50 deliveries happening per day in these hospitals, and the labor room staff, they are not, vaccination is not their priority automatically because they have to look at other emergencies. So yeah, so there are human resource concerns as well. So there is one staff nurse and one doctor, and there are so many deliveries happening simultaneously. So it is practically also sometimes challenging for them. But despite that, they are, coping up and starting to respond, and they are at least reporting now that how many deliveries they did, and out of which how many they are vaccinating. And all of this data is coming digitally. So every child is entered in the software, so we can track what happened to that child later on. So this is the availability of vaccines in the province. So if you look at this, the vaccination stock out is very minimal and only in a few districts, and that is also usually due to some mismanagement. It is not due to the reason that vaccine is not available. So there is no stock out of any vaccine anytime for the last 3-4 years. We just had a small stock out during COVID, and that was due to that delay in flights and delay in manufacture of vaccine globally, because the manufacturers, they were more focusing on COVID vaccine. So for that reason we had a stock out, but that was for very small interval. Other than that, we rarely see any stock outs. And this is the digital system which we are now using. So if you look at this, this is a little old slide, but from this month onwards, we are now getting same data from the teaching hospitals as well. So if you look at this, they tell us on a daily basis how many children were born yesterday, how many were vaccinated. And we are also, because a lot of births are happening in the private sector, we are also interacting with them and trying to bring them in the reporting network as well as in the vaccinating network. So the department provides vaccines free of cost to the private sector, and they can charge a minimum service delivery fees and give the vaccine to the children. So these MOUs are being done by the district health authorities with the pharmacies and private practitioners in their respective districts. Similarly, in order to improve the visibility of vaccination, because how many of you are aware that where the vaccination is available in Gangaram Hospital? Can you raise hand and tell? So see, not everyone, many of you are not aware. So the reason is that the visibility of these vaccination centers is very less. So we are also working on this and improving the visibility. We are giving them a proper branding and labeling right from the entrance of the OPD till how to reach there. So we are doing this, and we are also trying to train the security guards and the other support staff in the hospital, so that they can guide, they know what vaccination is and how they can refer someone, if they see anyone with a child, they can refer them to the vaccination center. And this is our e-system in which we are sending text messages as a reminders to the parents to vaccinate their children. And also sometimes we are doing robocalls for repeated defaulters. For example, if there is a child who has not been vaccinated for 6 months, so we and not responding to messages or outreach workers, so we are also calling them from the department's helpline. This number is not much high because making calls is very costly and it takes time and human resource as well. But we are working on another system in which the automated calls can also go. And this is the polygon system which we are using. So if you see the red blocks and the green blocks, so we know how many children are there in each block and how many children has the vaccinator vaccinated in the system. So once the number of children are entered in the software, that block becomes green. So we know that this vaccinator is working and the red one is not working, and then we ask them what their challenges are, why they are not working, and how we can improve this. इसको रिज्यूम पे दबा दें. And similarly, once we are tracking, so if you look at this slide, you will see that the vaccinators are named. So it is the name of the vaccinator and what is his immunization coverage. So we are tracking the performance of individual vaccinators in the monthly review meetings. So this meeting is held at the office of the CEO of the district for the district health authority, and they are doing this sort of analysis for every vaccinator. And similarly, at the provincial level, we are doing similar analysis, but at the district level. So we are providing the overall coverage for districts, how many vaccinators are working, how many are not working, how many are working but not reporting. So we have all that data, and we share it with the districts, and then they do the analysis at their own district level as well. And with all these IT reforms, we have been able to improve the coverage, which I showed in the first slide, from 49% in 2014 to 89% in 2022, just in a span of 8 years. So thank you, and if you have any questions, I'm here.
Thank you so much, sir, for this presentation. I think we'll take question and answers at the end. If everyone is willing, sir, with due respect, we'll take question and answers at the end. That would be well. Keeping in mind, Dr. Naeem, thank you so much. This data simply was a bit of a reliever for us, not a bit, but very good reliever that we have raised our EPI percentages to 89% through continuous monitoring, surveillance, and of course feedbacks, and keeping in mind the situation analysis reports. With this, I would like to add on that these surveys, these situation analysis tend to play a very important role in accountabilities and monitoring and evaluation. With me is Director Operational Research, Khan Medical University, Mr. Imtiaz Hussain. I asked him please to come on stage and give his talk on micro-survey immunization coverage.
Bismillah Rahman Rahim. First of all, thank you, organizer, for inviting us to deliver this important talk. I will take your 10 to 20 minutes to brief you on the initiatives we are taking in collaboration with the federal and provincial EPI program. So the initiative which recently mentioned by the Dr. Naeem in his presentation. So what I will do, I will take you on the outcomes of that important initiative which has been taken by the Honorable Secretary Health and his team for the improvement of the coverage in Lahore, because when we conducted the last round of the TPVX in Pakistan, so the Punjab was high performing district across country. That was good news as well. But in that, during that evaluation, within the Punjab, Lahore was not performing well. That was the low performing districts among other districts. So that's why some special initiatives has been taken, and details are already been shared by the Dr. Naeem. So what I will try to do, I will try to share the findings of that initiative with you. In addition to that, what we have conducted, so there are certain areas which are the priority areas in Lahore, which are the slum areas where government health facilities are not functional. So that in those areas, what we are working with Bill Gates Foundation for the functionality of the health facilities and strengthening the routine immunization. So where we conducted some activities, so I will brief you on that. And then we have some we have supported the district health authorities in reaching out to some unimmunized children in those areas. So I will brief you on that as well. And then there is a way forward in conclusion. So the first talk will be on the coverage survey, which we conducted in specifically Lahore, based on the request of the Secretary Health, after conducting the intensive exercise to improve the immunization coverage surveys in Lahore by engaging different program partners, for example, polio workers, COVID vaccinators, and many field forces. They have tried to improve the vaccination. Details are already been shared with you. So during that survey, what we tried to assess 3 key indicators. So where these indicators are. These indicators were part of our national survey that we conducted in 2022. To compare that, we focused on 3 indicators. In first target was the assessing the fully immunization coverage in Lahore, so that we will be able to compare it with the 2002. So what was the outcome of the recent intervention? That was the target. In addition to that, we also looking for the Penta 3 coverage, because Penta 3 coverage is also important indicator to look at. And then we also look at the cart retention, because the cart provision in cart retention is the primary indicator as well for the routine immunization. So that's why we also try to check what is the status of the routine cart retention as well. So as we are supporting the federal and provincial programs, so the methodology is set, the sample size calculation is on the website of the web portal of the WHO. This is an international standard immunization coverage survey manual available. We have to take support from that. So for that survey, what we did, we implemented the same methodology which we adopted for the national survey. We followed 2-stage cluster sampling. In first stage, we selected the locations, required locations, 64 locations across Lahore using the GIS approach. And then we went to that area and conducted the line listing, household line listing, to get the sampling frame of the eligible household for selection of the children for the evaluation. So based on the fresh line listing, so we selected 13 eligible children between the age of 12 to 23 months for the evaluation. And so this was the sample size estimates criteria. So this is the outcome of that survey. So we try to reach out around 134,000 households at that time. And then and the response rate was 93%. So if I will brief you on the coverage, so this was the coverage. So look at there were two age groups we have compared. The first one, which is recommended for the immunization coverage, that is 12 to 23 months usually used for the immunization coverage. So we look at the coverage of those age group. So the coverage was 85%, and there were 14.6% children who were partially immunized, and only 0.4% children were not vaccinated. Then we try to compare it with the younger age group. This is the coverage of the older age group who are 12 to 23 months. And then we try to look at the coverage of the younger age group. Those children, we went to in a household where 12 to 23 months was children available. And then we took that opportunity and also collected information from our children who was below 6 to 12 months as well to check the immunization status there. So the coverage was quite low, 73%. There were 26.3% partially immunized children. But overall, if you look at the coverage was 84%. And then if we look at the Penta-3 coverage, that is more than 90%, similarly for both groups. And the cart retention, look at the 84.4%. That is tremendous. So that was very high. Look at these areas. These are areas, the order of the performance, these 64 areas where we conducted this survey, these are the areas which have the more than 80%, 90% coverage. But look at these around 20 clusters, those have still less than 80% coverage. So we provide, you look at the coverage, that is more than 85%. So if we feel happy, so if we achieve this performance, so all is okay, that should not be happen. So that's why what we did, we try to present the positive aspects of the outcome as well. And with that, we also shared the areas which still need attention. So these were the areas which were very low or low performing. The list was all been shared with the authorities for the timely actions. And then what we tried to compare these findings with the previous round of surveys as well. So look at the coverage. If you look at the mixed Punjab, which conducted 2018, the coverage was 64% for the full immunization. In 2000, when we conducted the first round of the TP-Wix, that was 2020, the coverage was 76.4%. And then TP-Wix round 2, the coverage went down to 69.8%. Why? Because of the engagement of the vaccinator in COVID vaccination. That the work of the vaccinator was divided into two different priorities. So because of that, there was some decline. So to address that, this initiative was taken. So look at the progress, and then now after taking those initiatives, looking at the data, the authorities taken these timely decision, and that really impacted, and the coverage is now 85%. So this was an example. For example, improving a coverage from 69 to 85, 16% improvement in a 6 months period, that matter a lot. And this is a great example for the country as well, because there are a lot of areas, same human resource available across the country, all districts, because the polio workers are working across country, and they are going to door by door during the NIDs, SNIDs. So that's why now the Punjab has decided to extend this approach to other urban cities as well. And these initiatives are underway in another 10 to 11 districts as well. And hopefully we will evaluate those evaluations, those outcomes as well in early next year. So this is a Penta 3 coverage. There is the improvement, card retention, same improvement. And then what we have done. So this was the one part of the presentation that is outcome of the initiatives taken by the health department. And then we are running health facilities. As I mentioned to you earlier, that there are some pockets in Lahore where no government health facility is functional. So on the request of the provincial EOC, the emergency polio program plus the EPI program, with the support of the Bill Melinda Gates Foundation, we are running 7 health facilities in Lahore and 6 in Rawalpindi. And then by taking this advantage of this survey, we conducted this similar survey, Union Council specific survey in the Union Council where we are operating the health facilities. So I will brief you on that as well. Okay. So what was the outcome of that activity as well? So then same approach we adopted, 3 indicators we targeted, that was I already mentioned here. The same approach to make this usage specific power, so we targeted 90 clusters from these 7 union councils, so 15 from each. So we conducted this survey. Same methodology, same approaches. So this is the outcome. Look at here. So during these 7 health facilities, the coverage was there were 4 union council with the more than 80% coverage, and we found that the union council in which we are working, there are 3 union council with the coverage of less than 80%. Then we decided what to do now. And then we thought that the example of the Punjab government, the district, the provincial authorities, they have conducted the house to household visited. So we thought that is a best approach to follow. Then we thought to conduct a micro census in union council which is low performing. So we coordinate with the district authorities. We plan a micro census to visit each and every household by taking 3 advantages. The first one, to allocate a unique identifier number to household. Second target was to identify if the number of households in those areas who are eligible for the vaccination. And third was to check their immunization status at doorstep, either they are vaccinated, vaccination ongoing, or defaulters are not vaccinated. So that was the intention, and we decided to go for the activity. And then what is happened? So the activities are planned with meeting with the key field forces. Then we demarcated the boundaries, and then we visited house to house for the data collection and then data analysis. This was the whole process, so that will take a lot of time, so I'm not going into detail. So if you look at the outcomes, this is the outcome. So our teams visited each and every household. So by asking name of the household head, number of the population residing in that household, so these are all information. And then what happened? So based on that, we were able to visit 23,000 structure, 14,000 household, 87,000 population, 669, and around 11,000 under 5 children. And based on that, if you look at the number, the fourth one, so we identified around 1,000 children who were defaulted for the vaccination. And then we decided, if we have this number, what to do with that number? Should we keep that number as it is, or we should do something for that? And then what we have done, then we conducted meeting with the DHMTs, district authorities, and asked them to provide vaccines, trained human resource, and then we provided also human resource to organize line-wise outreach activities in those areas by taking that list in hand. So, and that was highly successful. that was a remarkable activity, and we reached to 90% coverage of those unvaccinated children. Or this was the subsector-wise coverage of the Union Council. Look at the coverage. In some areas, more than 90% response, 95%, 96%. So overall, 98% response was, we have get it from that. So look at here. These were the children who were the defaulters in the One Union Council. Look at the distribution. There is no selected pockets. This is across all the Union Council. But there were some gaps, some resource constraints, time constraints. So, but good thing is that there was no vaccine reluctancy there. But there was a lack of opportunities to either to reach them, either them to reach out the facility. These were some challenges. So we have to. And then look at these are the green dots where we reach out for the vaccination. All children, those were reach out for the vaccination. So this was, and then we thought that this is a great opportunity. For example, so, and then what we recommend that, we think that the rapid immunization coverage survey is an approach that offers a robust, quick, and cost-effective means of gauging coverage levels. For example, whenever you are investing something, there must be some indicators for the baseline, and then to measure the impact as well for time to time. For example, if you are investing some money for the improvement of the routine immunization, there must be some approach to assess the outcome timely. So what we are doing, we are now planning that wherever we are implementing, we are working, we are supporting Balochistan government as well, we are supporting KP, we are supporting Punjab as well. So wherever we are working, we are conducting a quick, in Karachi and other areas, we are conducting a quick immunization coverage surveys that only cost $2,500. And then we are conducting these biannually. And then we are emphasizing for the changing of the approaches and plans for those who are not performing well. There is no, if there is no appropriate change, significant change, so then we are recommending to change the directives, plans, and approaches. So in that way, we are thinking to overcome that one. So there are a lot of things, lot of good outcome aspects. So the presentation is available, will be shared with you. So I will not take that much time for you as well. So what kind of support this activity will provide? This activity will provide to allocate a unique identification number to the household, that provide facilitation to update the micro plans of the PI and EPI program, because there is a challenge for updating the micro plans for the polio team as well, for the EPI team as well. And then this activity identifies children with the incomplete or no immunization, that provide a base for the target intervention. And then if you look at the timely vaccination for the pregnant mothers, that because while you are visiting household, you can identify pregnant women and then you provide them TT vaccination as well. And then taking that advantage, you can reach out to their children as well for the timely vaccination. So there are lot of good outcomes. For example, if you target biannually, if you conduct a biannually micro census in an area which needs urgent attention, like District Union Council in some part of Sindh, in Balochistan or KP, where the coverage is less than 50%. What you can do, instead of other efforts, if you conduct 2 rounds of the micro census in a year, so those 2 rounds will provide at least an opportunity to provide them BCG, provide them 2 times of the measles vaccine, one time, and then that provides opportunity 2 times for the IPV. That provides 2 times opportunity for pentavalent and other vaccines as well. So, other than the facility base, other than the routine immunization, if you conduct 2 rounds of the biannual micro census, that substantially contribute for the reaching out to every children, every target for the timely vaccination. That is our intention, and that is our message. So, and then so in that way, what we can do, we can reach out to every child for vaccination and support the government of Pakistan, federal EPI, plus provincial authorities to reach out to every child. So this was my presentation, and if you have any question, so please feel free to ask questions. So we will provide our response after this session. So thank you. Thank you.
Already has good coverage, and out of that only Lahore has very poor coverage. And what about the Balochistan and PGP where it is already, people are practicing for the vaccination? Did you have any surveys over there also, like such studies, to find out what is the possibilities and this is all done in Lahore?
No. Yes, sir.
There are not many people not getting vaccination to the private sector also. What about the Balochistan where it is already less than 50% and are there any studies that are simply going on? Why the people are not getting vaccination over there?
Thank you, sir. Thank you, sir. Yes, we conducted the survey we referred earlier. So we conducted 2 national scale surveys targeting district specific outcomes. So we conducted these surveys in all 152 districts of the Pakistan. So aiming to identify these gaps as well. And then what we did, we as a academia.
These all indicate that these all have been done in Lahore.
No. So I am presenting only Punjab on the request of these researchers. So we conducted same initiatives in Balochistan. We conducted same initiatives in Sindh as well. So the topic of my talk for today was the Lahore specific. Yes. Yes.
Very nice presentation. My name is Dr. Heba Haider. I'm a general pediatrician, from US. This is my alma mater. So my question is, I noticed that the immunizations that children receive, so the database is there's no national or provincial database. There is?
No.
There is not.
No.
Is there any vision of starting a database like that? Because that will help instead of carrying those cards or writing on those cards, which can get lost. And then there's a risk of, redundancy or doing the vaccinations again. How can we, is it any vision or not?
So Dr. Naeem already mentioned in his presentation that Punjab already started this initiative since 2014 or even earlier as well. So they have a electronic registry as well. So Naeem will brief you as well on this.
So in Punjab we have previously we
right. All right, so I think I'm just going to use these 20 minutes as an opportunity to talk to a lot of people, which include physicians, policymakers, implementers, and analysts. And the reason is that we have talked a lot about childhood vaccination. I mean, can you hear me now? Okay. So there has been a lot of talk on childhood immunization, but nobody talks about adult immunization. And I'm sure that each one of you in your practice during your rounds, you see a lot of pneumonia patients, a lot of pneumonia elderly patients, but we haven't done anything about them. So here's a request to all the policymakers, the implementers, the epidemiologists, to set up an EPI program for adults. The two concerns that I have heard from physicians about adult immunization is immune senescence, and then compounding immune senescence is the comorbid conditions. So immune senescence, which means that these individuals are not able to elicit an immune response which may be protective. And then further compounding that thing is their comorbidities. And one of the comorbidities that's very common in Pakistan is type 2 diabetes. I mean, definitely type 2 diabetes do impair the immune system. So my talk is going to be at the cross-section of infection and the comorbidities. And hopefully by the end of those 20 minutes, I would have convinced you enough that these individuals, despite of their age and despite of their comorbidities, can still elicit an immune response which is protective. So as the title of my talk says, immune response to PCV10 in adults with and without type 2 diabetes. Let's look at the numbers first. So globally, there are about 2.3 million community-acquired lower respiratory tract infections in people of all ages. Incidence of, once again, somebody just talked about the registries. Unfortunately, in Pakistan, we don't have any data. So you just have to do your own digging if you are actually looking for some numbers. But in the United States and UK, people are keeping track of everything. And that helps to understand the prevalence of infection, incidence of infection, and then the impact of vaccination or any other kind of preventive therapies. So here you see 1 million deaths in adults over 70 years of age. And most commonly isolated pathogen in all of them was Streptococcus pneumonia, and unfortunately Streptococcus pneumonia is a vaccine-preventable infection. Comorbid conditions that were primarily associated with pneumonia were diabetes, CVD, and COPD, the chronic obstructive pulmonary disorder. Locally in Pakistan, and this data again was published by Aga Khan University, 7.1 million cases of pneumococcal pneumonia in children in the last 5 or 6 years. In children of 5 years or less age, 63,000 deaths in children. However, unfortunately, we don't have any data on adults. Most of the data is extremely fragmented and it's not collated so far. So we tried to take a stab at it, and we collected some samples from a local laboratory. And here, it's a very simple graph. And right on the top of it, the remarkable thing that you see is that even post-PCV vaccine, and people talk about herd immunity, and here is an example, that herd immunity doesn't seem to be working. And I'll tell you the reason why the herd immunity doesn't work in case of Streptococcus pneumonia, because Streptococcus pneumonia is an ever-evolving pathogen. Now you see that in case of, so on your y-axis, you have the number of isolates, and then here we are looking at years. And in every year post-introduction of PCV10, yes, there is a decrease in the incidence of pneumonia in children or the incidence of pneumococcal infection in children, but there is a rise in the infection of adults. And this goes across the board in 2018, 19, 20, all the way up to 23. The numbers are pretty consistent. They are about 72% to 68% of infections that are occurring in adults right now. And yes, the numbers are going down in children, but unfortunately it is not impacting the numbers in adults. Now, if you distribute these numbers over the site of isolation, you can see that you can isolate them from blood, which means that they have pneumonic bacteremia. You can also isolate them from CSF. And these numbers actually correlate with the CSF or the meningitis numbers in other countries as well. So these are number of isolates. So you can see that in both 2019 and 2021, we have decent number of isolates coming out of the CSF. And they are not just in adults. You can see that there are some that are coming out of children as well. And then in sputum, which indicates pneumonia, 32 of these isolates in 2018 were coming from adults. And then in 2023, still 19 isolates were coming from. Yes, the data is very little, but we need to dig in more deeply. We need to, like they say, make a registry and try to understand the status of the disease and the burden of this infection in children as well as in adults. Now with adults, the problem, like I said initially, is comorbid conditions. And one of the comorbid conditions that is very common is diabetes, and I'm going to address it in just a minute. But before that, we tried to look for the serotypes. So pneumococci so far had about hundreds of serotypes, a total of 101 serotypes. So you can tell how different pneumococci is. So if you look at the distribution of serotypes, and I have divided it by different ways. So the serotypes which were primarily present in disease versus carriage, then serotypes that were present in children who were older than 5 years of age and children who were younger than 5 years of age. And then we have also distributed it by male and female. The first thing that you see is the remarkable diversity of the serotypes that we are seeing coming out of these samples. The other thing that that's very obvious is that two serotypes, which are serotype 1 and serotype 19F, are primarily associated with disease. And the funny thing is that both of these serotypes are included in PCV10, which means that these were being immunized, the children were being immunized with PCV10, and yet you have these serotypes circulating in the community. The other serotype that came out was serotype 9L, and this serotype is primarily associated with carriage. And because carriage is predominantly associated with children, so you can see like right here that most of these isolates were coming from children who were younger than 5 years of age. But if you look at these two serotypes, which is serotype 1 and serotype 19F, the distribution is pretty even. In case of serotype 1, mostly it is coming from adults, and in case of serotype 19F, it is primarily coming from children. Now going back to adults, diabetes is one of the most important comorbid conditions in Pakistan. And 26.7 is a kind of a moderate, but I think it has gone up to 33% prevalence of type 2 diabetes, with approximately 3.3 million people that are currently affected with diabetes. And diabetes ranks, Pakistan actually ranks third in terms of the prevalence of type 2 diabetes, which is not a good list to rank, not a good list to top. Now putting diabetes and pneumonia together, of course, diabetes increases the risk of community-acquired pneumonia by 2 to 4-fold. They occur more frequently in individuals who have diabetes, and these infections can be more fatal in people who have type 2 diabetes. However, we do not have any recommendations for immunization against this organism that causes pneumonia. So what we did, we took upon ourselves and we asked a question. Are immune responses in individuals who are elderly and have diabetes similar to the immune responses that are in elderly but they don't have any comorbid conditions? So our study was actually embedded in one of the hospitals in Lahore, the Shalimar Hospital. We selected, it's a very small study, we selected about 40 participants. The participants were selected by an endocrinologist and the diabetologist. We divided them into two groups, one with type 2 diabetes and then age-matched controls with no diabetes. We gave them, we immunized them, we collected samples at day 0, Then we collected them at day 14, day 28, and 6 months. We were trying to look at the kinetics of the immune response. We were also trying to measure the strength of the immune response and the magnitude of immune response over a period of time. And the idea behind those experiments is to see if people with diabetes are failing in generating or eliciting a protective immune response at any one of these stages. And then eventually we measured the humoral immune response, which primarily included measuring the concentrations of antibodies. And then we also measured functionality of antibody, because just reporting titer is not sufficient, because you don't know whether those antibodies, yes, they may be producing a tremendous amount of antibodies, but they may not be protective. They're just there. So we did another study, which is to measure the functionality of antibody. The third study that we did is ELISpot, which is actually what happens is that the most important thing about the vaccine is the memory response, which means that the vaccine, whenever your body looks at that antigen post-immunization, it should be able to elicit an immune response, and that is called memory. So it's also a recall response. So here's the number of samples and the follow-ups. So we followed them up. The T1 was 14 days, T2 was 28 days, and finally T3 was 32. It was supposed to be 6 months, but unfortunately because of COVID, it extended to 8 months. So we first looked at the baseline response. Baseline response means that these people have been exposed to pneumococci. They were not immunized. They were not given any kind of vaccine against pneumococci. This was just plain baseline response. And in baseline response, you can see that each one of these individuals, be it people with diabetes or without diabetes, they are eliciting an immune response to 19F, which was primarily found in adults. They are also eliciting an immune response to serotype 1. They are also eliciting immune responses to other serotypes. These two dotted lines that you see here, these are the cutoffs that are set by WHO, the World Health Organization. It recommends this, so it's a surrogate assay to measure immunity against vaccine. And they're saying that if children produce antibody titer, which is above 0.35 micrograms, then they will be hypothetically protected. If adults produce a titer of 1.3 micrograms, they will be hypothetically protected against pneumonia. And you see that these people are eliciting a decent amount of immune response, and you don't see any significant difference between those who are diabetics and those who are non-diabetics. Secondly, we immunized individuals, and then after immunization, we started to measure the immune response again. And you see that they elicited a very decent immune response. The immune response started to appear at T1, which was 14 days post-immunization. At 28 days, the immune response remained consistent, and then in 6 months, the antibodies started to wane, but they didn't go below detection limit and they didn't go below protective limit, which means the circulating antibodies in your body are still going to be able to protect against pneumococcal infections. And we see the same trend in all of these serotypes that we tested it against. We tested it against serotype 19F, we tested it against 9V, we tested it against 1, and we tested. So against 18 serotypes, this is pretty decent evidence that these people are able to elicit immune response to most of these serotypes. And the immune response is pretty high, so which means that they will be protected if we give them immunity. If we compare diabetics to non-diabetics, yes, the diabetics are not producing as higher a response, or the magnitude of the response is not as high as you see in non-diabetics, but nevertheless, at all time points, it actually remained above the protective level, which means that whatever antibodies they are producing, they should be able to protect them. Next, we wanted to see if you can compare these 3 different serotypes among each other. And yes, they produce different titers to these 3 serotypes, but nevertheless, their titers were decent enough or high enough to protect them. When you compare these titers to non-diabetics, the non-diabetics definitely elicit a very high titer. So this whole thing is like a snapshot of all the serotypes that we have performed. Next, we wanted to do OPCA. Now, what happens in OPCA? It's a simple immune response. You have complement in your serum. You have antibodies here. The antibodies and the complements are going to opsonize the bacteria, and this opsonized bacteria will be taken up by by neutrophils. And it's a very simple response that occurs in our body. And what we are doing here is that we are eliciting antibodies that are specific to each serotype. And then you can measure this killing by simply plating your bacteria on nutrient agar or on blood agar. When we did OPCA, what we found is that each one of these individuals, be it diabetic or be it non-diabetic, they have a very decent OPCA titer. So the OPCA titer that is suggested by World Health Organization is about 8, which means that if anything that is above this titer should be protective, which means that most of these antibodies that were produced in diabetics and non-diabetics were able to kill the bacteria. They were able to drive the bacteria inside the neutrophils, which means that the killing was occurring. And you can see that at all time points, there was a decent OPCA titer. The OPCA titer, like I said, was significantly different between diabetics and non-diabetics, but nevertheless, even the diabetics were eliciting decent titer. However, in diabetics, they started to wane at the 3rd time point, which is okay, but still you have decent amount of titer left behind. Now we wanted to see if if glucose control or if diabetes control have anything to do with the antibody titer or with the OPCA titer. We see a moderate negative association of HbA1c with the OPCA titer, which means that the poorer your diabetes control, the lesser will be your OPCA titers, and that is exactly what we have seen in your practice as well, that people who are poorly controlled, poorly diabetes controlled, they do not respond to infections very nicely. So finally, in conclusions and way forward, first of all, genomic surveillance. I showed you how diverse pneumococci is. So we really need to implement genomic surveillance, which means that as soon as there is a new strain out, we should be able to flag it. Individuals with type 2 diabetes elicit protective immune response, so please do something to vaccinate, to immunize elderly, and especially elderly with type 2 diabetes. Antibodies demonstrate moderate functionality in diabetes and non-diabetes, and trust me, this is sufficient to protect them against any kind of infection. Studies should be repeated with a larger population, and then immunization recommendation in elderly, in particular elderly with comorbid conditions. My acknowledgements to all those people who have worked with me, especially my PhD student Azaz Ahmed, Dr. Bilal bin Yunus, who is the endocrinologist at Shalimar, the staff of Shalimar hospitals, all individuals who participated in the study, and my lab group. Thank you.
Thank you, Dr. Shahar, for emphasizing the importance of PCV10 among diabetes and non-diabetes. We are honored here to have our Vice Chancellor, Professor Dr. Khalid Masood Gordar from Imtiaz. Sir, please come up on stage. Our Registrar Sir, Professor Dr. Nadeem Kasumi, thank you so much for coming. The chief guest of today's session, Professor Rashid Mahmood Saab, sir, please come up on stage. FJMU Chair, Professor Dr. Fawzia Saab, please come on stage. I'll ask Professor Dr. Khalid Masood VC Saab to please come on stage to shed some light. Thank you.
बिस्मिल्लाहिर्रहमानिर्रहीम। आज तो स्पीचेस हमने स्पीकर्स की सुननी है, बट आई एम वेरी हैप्पी टू सी कि فائنل ایئر کلاس کا رسپانس بہت اچھا. اور دی 4 sessions they are going on a parallel session. میرے خیال موسم ٹھیک ہے, پنکھے کی ضرورت نہیں ہے یا غلطی سے چل گیا ہے. اور ویسے یہ بھی ہوتا ہے اگر تقریر کرنے کو بندہ آ جائے اور ایکسپیکٹیشن ہو کہ لمبی تقریر کریں گے تو پنکھا چلا دیا. اس موسم میں ویسے ہی مختصر ہو جائے گی. تو آڈیٹوریم میں آئی تھنک دی فنکشن از گوئنگ آن, جس میں دی ایمیننٹ اسپیکر فرام US اینڈ UK دے آر انٹریکٹنگ. اسی طرح اینڈوکرائن کا بڑا اچھا ایک سیشن جا رہا ہے جس میں پروفیسر تابندہ اور ڈاکٹر راحت بات کر رہے ہیں. اور نیچے ریپروڈکٹیو ہیلتھ جس پہ گائنی کے اسپیشلسٹ موجود ہیں, اور ویکسینیشن پہ اس حال میں 4 parallel session آئی تھنک ان دا ہسٹری آف FJMU, جس میں تمام ہال دے آر جیم پیک. اور میرا خیال آپ سب کو ہی کریڈٹ جاتا ہے. اینڈ آئی ایم ویری گریٹفل ٹو آل دیز. عثمان صاحب بھی آئے ہوئے ہیں, ویری گریٹفل ٹو عثمان صاحب اینڈ ایوری بڈی. نعیم صاحب موجود ہیں, سارے ایمیننٹ اسپیکر ہیں. اور FJMU is blessed to have an excellent seminar today with the help of CAMCA UK. We are thankful to the CAMCA UK and FJMU UK دونوں. اور کمیونٹی میڈیسن ڈاکٹر تسکین اینڈ ڈاکٹر ہبا حیدر. You know ہبا حیدر is the president of FJMU alumni of US. ہبا نے پتہ نہیں بات کی ہے یہاں پہ کہ نہیں کی. نہیں, ہبا کو بھی اسٹیج پہ بلا لیں. میڈم آ جائیں. اصل میں تو اس سارے فنکشنز کی جو 2 کوئنز ہیں, اس میں ہبا حیدر اور وردہ, یہ 2 کوئنز ہیں ہماری سارے فنکشنز کی. ایک US alumni کی پریزیڈنٹ ہے, دوسری UK alumni کی پریزیڈنٹ ہیں. اینڈ وی آر گریٹفل ٹو دیم ود دا فیکلٹی آف فاطمہ جنرال میڈیکل یونیورسٹی. سیمینار آن ہے. سو تھینک یو تسکین, اور ہبا سے ہی شیلڈ دلوائیں, میں ساتھ ہوتا ہوں.
So Dr. Heba, please come forward for the shield distribution, please. Thank you, Doctor.
بیٹھے بیٹھے مجھے بھی
I think I'm welcome all the other distinguished guests. Sir, آپ بھی
شیلڈ
on the chair.
جنہوں نے لینی ہو درمیان میں آ جائیں. لال اسپیکر.
First of all, please I welcome Dr. Naeem Majid from CAMCA UK chair to please come upon stage.
ایسے کریں گے تو تصویر اچھی آ گئی.
I think we'll keep this shield for the picture purpose. ہم بعد میں اسپیکر کو پڑھا دیں گے سر کا فارمولا جو ہے.
اچھا, نیکسٹ پلان.
ہاں جی. پلیز ویلکم ڈاکٹر امتیاز حسین. Please put your hand together for his presentation. Next presenter, Dr. Shapar Mirza, please come upon stage for the presentation. Next we have Dr. Imran Nasir. Please come upon stage. We are still left with 2 presentations, and I hope کہ بعد میں اب شیلڈ سے ایک دفعہ ہو جائیں تو پھر اس کے بعد we'll continue with that session. Next, Mr. Usman Khalid from Feroz Sons, please come upon stage. The shield from FJMU to Professor Heba. आप आगे चले जाओ बेटा. And the next chief response, chief guest. Professor Dr. Ashish. Thank you so much. Thank you so much, sir. We'll continue with the session.
Dean makes that mistake. Right. So I was about to leave, but after getting the shield. So, but anyways, all right. Okay. So are we good to start? Thank you very much, everyone. So I'll be talking about introducing the HPV or the human papilloma virus vaccine introduction in Pakistan. Step towards preventing cervical cancer. As you might be, aware, that's the only cancer for which we have the vaccine available by virtue of its being caused by an infectious agent. So this is going to be my outline of my presentation. I'll give you some background on the burden of the disease, the vaccines that exist, what are the current WHO recommendations, and what are the where do we stand in terms of the introduction of the vaccine in Pakistan. So the human papilloma virus is a non-enveloped DNA virus with more than 200 plus types and affects skins, genitals, and throat. It is sexually transmitted, and as per WHO, 291 million women globally are estimated to be infected. Average prevalence in healthy women is around 10%, but the HPV infection varies greatly depending upon the factors such as age, gender, sexual behavior, and geography. Although there are more than 200 plus types, there are only a few types that are of interest to us. Primarily the HPV 16 and HPV 18, which are known as the high risk types, and they're responsible for 71% of all the cases of cervical cancer. Then there are other low risk types which are important, in particular HPV 6 and HPV 11, which are mostly responsible for causing benign lesions of the skins, warts at other parts of the body. So, in terms of the types of cancer, HPV can cause a variety of different cancers. Not 100% attribution of these cancers can be traced back to HPV alone. It's responsible for 91% of the cervical cancers, 69% of the vulvar cancers, 72% of the oropharyngeal cancers, 91% of the anal cancers again, 63% of the penile cancers, and 75% of the vaginal cancer. So the most common of these is the cervical cancer, and what we know is that more than 91% of the cervical cancers have an underlying HPV etiology. So how does the normal cervical cells progress to cancer cells? This is just an illustration demonstrating, again, on the extreme left side you see the normal cytology of the cell of the normal cervix, and in the presence of a transient infection, when the cervix is infected for a transient period by one of the high-risk strains, the HPV 16 or 18, you see some changes in the morphology, and with persistent infection you see further abnormal changes, and CIN3 is what we then known as the carcinoma in situ phase, which can then progress to the cancer when it spreads to tissues outside, or the invasive lesion. So as we move from the low-grade lesions to the high-grade lesions to cervical cancer, the greater proportion is caused by these two specific strains, the HPV 16 and HPV 18. I'm not sure why the fonts are, kind of looking like this in this presentation. Anyways, so talking about the global burden of HPV, there are more than 604,000 new HPV-related cases, resulting in around 340,000 deaths, which is 8% of all cancer-related deaths. More than 90% of these occur in low and low middle income country, and the highest incidence and mortality is in sub-Saharan Africa. Coming to Pakistan, there are more than 73.8 million women who are at risk of cervical cancer. So these are women who are aged 15 and above. So this is then in epidemiological parlance are classified as women who are at risk of developing cervical cancer. Based on the various modeling estimates and some data from the cancer registries, it is estimated there are more than 5,000 annual cases that result in more than 3,000 deaths, ranking it as a third leading cause of cancer-related deaths in reproductive age women. And I do believe this is most probably an underestimate, and the actual number of the cases might be higher than that. Of these, 88% of the cases are linked to HPV serotypes 16 and 18, and age standardized cervical incidence rate is 6.1 per 100,000 women aged 15 years and above. There are effective vaccines available against HPV. There are currently 6 licensed vaccines available in the market. 3 of them are bivalent vaccines that prevent against HPV 16 and 18, and with some cross protection against other serotypes like 31, 33, and 45. There are 2 quadrivalent vaccines that protect against both the high risk and the low risk serotypes of interest, 6, 11, 16, and 18, commercially known as the Gardasil by Merck and Servavac by Serum Institute of India, which is a newer entry into the market. And then we also have another version of the Merck vaccine, the Gardasil 9, which is a nanovalent vaccine and protects against 9 different serotypes. The underlying technology behind these vaccines is recombinant DNA technology using the HPV-L1 capsid proteins, which self-assembles into non-infectious forms of virus-like proteins. Since the virus-like particles contains no genomic material and no live HPV, it is non-infectious and is hence non-oncogenic. And the first generation of the HPV vaccine was approved in 2006. It is when it's got the FDA approval. This is like a brief schema describing how the technology behind the vaccines for HPV works. It starts with the production of a protein monomer, which then form pentamers and then self-assembly into a HPV vaccine-like particle, which is free of the DNA. Currently, the WHO recommends that all girls aged 19 to 14 years must get at least 1 dose of HPV, or 1 or 2 doses of HPV. Anyone from 15 to 20 years, again 1 or 2 doses of vaccines, and greater than 21 years of female should get 2 doses of HPV, which are 6 months apart. For the immunocompromised individuals, including those with HIV, the recommendation is that they should receive up to 3 doses. So the data on decreasing the number of doses from 2 to 1 is based on various studies, which have shows that equivalent number of equivalent antibody titers are achieved even after administration of 1 dose after a long interval follow-up going as long as 10 to 12 years. So in this figure, what we see is that antibody titers on the top are for the 3-dose, the middle one is for the 2-dose, and the bottom one is for the 1-dose. And what we see is that the 1-dose titers, even they're sustained after 10 to 11 years, which are enough for the protection against HPV. So based on that, WHO revised its recommendations too, and it's considering the, it makes the introduction of the vaccines more cost effective and practically more feasible. As of 2022, 127 countries have introduced the HPV vaccine in their national immunization programs. The WHO recommends a life course approach to cervical prevention and control, which includes, prevention by vaccination, secondary prevention by screening for HPV, and tertiary prevention by early treatment and in cases of invasive cancers, a combination of radiotherapy, chemotherapy, and palliative care. And within the Sustainable Development Goal framework, the target is to what is known as 90-70-90, which basically means that 90% of the target is to get 90% of the girls fully vaccinated for HPV, and 70% of the women received a screening test, at least one between 35 to 45 years of age, and 90% of the women identified with cervical disease received treatment and care. So this is a part of the United Nations Sustainable Development Goal for 2030, and target number 3.4. So this was a modeling study done some time back in Pakistan, and which shows that if we are able to increase the HPV vaccine coverage to 90% with intensive screening and vaccination, we will be able to avert as much as 111,000 to 133,000 cervical cancer cases during this intervening period. Right, so it is a huge number in terms of not only life saved but also dailies averted. So where do we stand in terms of HPV vaccine introduction in Pakistan? So in the global context, the vaccine first approved FDA approval in 2006, and since then it has been introduced in more than 80 countries. In Pakistan, the vaccine was available in the market in 2018 and 19. Then for a variety of reasons, with the pandemic contributing and logistic reasons, the vaccine was not available for a long time. And currently there is no data for its coverage, or there is and also no official reasons for the discontinuation. In 2022, the government of Sindh announced the launch of the HPV vaccination programs targeted towards adolescent girls in school, beginning from Karachi. There was a national seminar on HPV in Karachi in July 26, in which JPIGO and other interested parties took part, and there was a cervical cancer elimination introduction of HPV vaccine in Pakistan, announcement by the Federal Directorate of Immunization towards the end of November last month, which states that its intention to introduce the vaccine, HPV vaccine, in the EPI program, but there are no specific dates that have been given so far. Concurrently, the Aga Khan University is planning a globe HPV study, which is going to assess the incidence and prevalence of HPV in females of reproductive age. So this is the AKU Globe HPV study. It's funded by the International Vaccine Institute and the Bill and Melinda Gates Foundation. What we are planning is we are planning 2 cross-sectional surveys, one in an urban area, peri-urban area in Karachi, and one in rural Sindh, with a sample size of 2,000 each, and target age of 9 to 50 years of age. And then we have another cross-section study of with a special population of commercial sex workers, and with a sample size of 250. And then we are again following a 500 sample size of cohort for longitudinally to ascertain the incidence of HPV and the transient carriage over a period of 2 years. So these women will be followed for a period of 2 years, and the samples will be repeatedly taken at the time of enrollment and subsequently at 6 months interval. So at the end there will be at the end of the 2 years there will be 5 samples that will be collected from each woman. So the future plans hold, what the future holds is that, we should harness the support of Gavi, the vaccine alliance, similar to the model that was adapted for the typhoid conjugate vaccine, and introduce the HPV vaccine in the expanded program of immunization in Pakistan. What the recommendation is that when you introduce it at first, it should be coupled with a catch-up immunization for all women of beyond 15 years of age as well, and then it becomes part of the routine immunization, and these mass immunization activities can then be used as an opportunity to evaluate the effectiveness of HPV vaccine in a catch-up campaigns. Some of the challenges that are expected is that that is globally, that has been also been seen, is that for the coverage of 2 doses, it's only around 13%, but with the new data coming in that the 1 dose is as effective in providing protection as 2 doses, it helps to achieve the targeted coverage. And it also, since the vaccine is also in limited supply, the single dose will reduce the supply burden, and it decreases the cost as well. There are programmatic challenges since the EPI has largely focused towards the children, so expanding the program to include the adult or adolescent girls does in itself poses different challenges. These are some of my references, and I'm happy to answer any questions. Thank you.
Thank you so much, Dr. Imran. HPV vaccination is a very crucial topic among women in Pakistan, and I hope it meets up the challenges and local companies start manufacturing HPV vaccination in Pakistan as well. So let's welcome Mr. Usman Balid from Feroz Sons. He'll be talking about manufacturing vaccines in Pakistan. Please give him a big hand. Thank you.
Bismillahirrahmanirrahim. I'm very grateful to Dr. Taskeen and the organizers for inviting me, and I apologize for the last minute changes in schedule, unfortunately. But so my talk will be the least scientific of all the talks you have heard today, but hopefully it should identify basically what the core problem is and why Pakistan is, after 75 years, unable to produce any vaccines at scale to any meaningful level. So if you look at the demographics, this definitely should be one of the biggest markets in the world for vaccine manufacturers, and there should be no logical reason why Pakistan should not be self-sufficient in the manufacture of vaccines. As you know, we are the 5th largest population in the world. We have almost 20,000 live births every day in this country. The world's 3rd largest birth cohort, over 6.5 million babies born annually. And if you look at the need for prevention or protection of our babies, we're one of 5 countries in the world which together account for 50% of deaths of children under 5. Each year, more than 350,000 children die before the age of 5, and one of the major causes of these deaths is vaccine-preventable diseases. Coverage, of course, remains a challenge. You've heard that, but I think Punjab has shown the way and is really a role model not just for the rest of Pakistan, and shows where a little bit of determination, political will can play such a massive role in protecting the population. And it also shows, alhamdulillah, that there is no shortage of talent, human resource talent in this country. When we put our minds to something and we put our resources behind it, we can achieve anything. So I'll come to this again in the end also, because with a population of almost 240 million people, at least 4 or 5 major vaccines should be produced at scale here. This include pneumococcal vaccine, and Dr. Shaper presented a wonderful paper on the link between diabetes and pneumonia. Pentavalent vaccines, of course, IPV. It's such a shame that even today we are not polio-free in this country. But part of the problem is, of course, that the support we get from outside. We don't like paying for anything. And unfortunately, that disturbs the economics of Pakistan's health system in a way that it actually prevents self-sufficiency rather than encouraging it. So I mentioned that these are some of the viruses that should be immediate opportunities for any manufacturer looking to supply vaccines profitably and at scale. The need for local production, of course, is it has been shown around the world that if you are locally self-sufficient in vaccine production, it boosts immunization efforts. Governments put more resources behind vaccinating their populations as well. As we know, most vaccines require cold chain storage and distribution. And particularly in the post-COVID era, when there are so many disruptions in the global supply chain, inefficiencies in the global system, but also, of course, in the local logistical chain around vaccines, cold chain storage, these combine to create challenges when you're looking to import vaccines every time. And we can see that in the current flu season, that we often run short of vaccines when we need them, and then suddenly there's a lot of expiry at the end when the season is suddenly over and the vaccines have just arrived. So local production can help resolve a lot of these challenges. Countries like in Latin America and Africa, Mexico, South Africa being 2 examples, have started producing their own vaccines to produce their immunization programs. Ultimately, it is hoped that local manufacturing will also lower the cost of vaccines, but it will certainly make the supply more reliable. And buying vaccines from global suppliers, as we saw at the beginning of the pandemic, does not guarantee a security of supply. It's an unfortunate fact that the more privileged countries are the ones that are likely to receive vaccination first. There is capacity in Pakistan to produce vaccines. So at the start of the COVID pandemic, our company was one of 6 manufacturing facilities worldwide that were licensed by Gilead Sciences, which is an American biotech company, to produce the first therapeutic. So this is not a vaccine, it was a therapeutic for treating COVID-19. And we were licensed to supply to 127 low and middle income countries. Over the course of the pandemic, we supplied actively to about 24 countries and covered over 100,000 patients in almost every continent during the course of the pandemic. So this was a recognition by the international pharma industry also that Pakistan has potential and it has capacity to actually deliver at scale. This is just an example of the kinds of investments that have been made in the last 5 to 10 years in pharma in Pakistan. You could compare these areas to any site in the world. They're world-class facilities. And vaccines basically take 2 potential forms. One is either vials or ampules, and the second is prefilled syringes. So this is our plant in Lahore. You're all welcome to visit it whenever you like. We'd be very honored to arrange a visit between FJ and Feroz Sons. But just to give you an idea of capacity, this plant has the capacity to produce about 75 million multi-dose vials per year, which means 750 million doses per annum potentially of a vaccine. Unfortunately, it won't be producing vaccine. I will explain why, but it's about to come online and we'll be producing products like insulin and other important products, but unfortunately, vaccine still remains a dream. In pre-filled syringes, this is the largest capacity in Pakistan, again, about 30 million syringes per year. And pre-filled syringes are mostly used in adult vaccinations like hepatitis B, HPV. So there is a lot of potential to produce these vaccines here, but there are significant barriers also. The first thing we have to recognize with vaccines is that unlike medicines, vaccines are a public good, which means people, the population, citizens almost never buy their vaccines. It is governments that purchase vaccines and vaccinate their populations. That's just how it works. It's not just in poor countries like Pakistan, but if you look at the richest countries in the world, and US and Japan are two prime examples, whenever they look to immunize their populations, the government takes on that responsibility. It does not require citizens to purchase vaccines. We just spoke about the flu vaccine, and that's one vaccine which is an entirely private market vaccine in Pakistan. And despite the post-COVID raise in awareness around influenza, and the need for vaccination, the total number of doses that are sold in Pakistan are 300,000 to 400,000 in a year. That would be, just to give you an idea, 1 to 2 days production of this plant that you just saw. So there is no way you can produce at scale if you don't have a buyer for your vaccines. And unfortunately, this is the fundamental problem that we are still trying to grapple with in Pakistan. So it's really the economics and not the science that is the real barrier. During COVID, once we got the opportunity to supply these other countries, we made a large investment, about $25 million, to expand our capacity to produce vaccines. And of the two major mRNA producers, we were in advanced talks with one of them to produce mRNA vaccines in Pakistan. They had an online Zoom series of meetings with the government of Pakistan, but in the end, the government refused to give any guarantees of vaccine offtake, and that's why we are not producing that vaccine today. Otherwise, the same facility would be producing mRNA vaccines. The basic problem is that right next door in Afghanistan, a government that we often berate for its lack of adherence to human rights, the World Bank figures show that Pakistan spends less than 3% of GDP on healthcare, and even Afghanistan spends almost 5 times our amount as a proportion of whatever little resources the country has. And because there is no commitment towards a preventive public health strategy, we see all the fallouts, whether it's in our immunization numbers, Punjab being an exception, and also in the way that the government tackles health challenges. It is much more likely for the government to build a second or a third PKLI because tertiary care looks very politically compelling. And primary preventive care, unfortunately, does not give that shiny look to a government that they seek. And that is why, unfortunately, particularly in a resource-constrained country like Pakistan, it's a shame that we, at the tertiary level, have some of the best facilities in the world. And at the community level, we have almost no health system to work with. Ultimately, this affects also the perspective to produce vaccines. And finally, because of all these issues, there is limited to zero trust between the public and the private sector. Being in the pharma industry, we are often challenged by the government that India is right next door to Pakistan. India, just to give you an idea, produces 70% of Gavi vaccines globally by volume, 70%. So if India were to shut down, there would be no vaccines in the world. That's how big a production center India is. Their pharmaceutical exports are crossing $28 billion this year. Pakistan is at $300 million. So we are often asked by government, and it's a very valid question to ask, that Pakistan ka kya hua? Why isn't our industry performing to those levels? And I'll explain that to you right now. The first challenge, of course, as I mentioned, is that we don't like paying for things. So because Gavi covers most of the vaccine requirements of Pakistan, those are done internationally in international tenders and produced largely, as I said, in India. In Pakistan, if we were to start producing vaccines, for us to be able to supply to Gavi or to be eligible to supply to Gavi, the vaccine units in Pakistan would first need to be pre-qualified by the WHO. For those vaccine units to be pre-qualified, the National Regulatory Authority, which is DRAP, has to first be has to be certified by the WHO itself. So if a regulator is not pre-qualified, there is no way any plant in the country can be pre-qualified. So it's a chicken and egg situation. And because the government locally doesn't, want to buy vaccines, then we have absolutely no market. We can't export because there is no WHO pre-qualified regulator, and we can't sell locally because the government is just not interested in buying. So I'll just give you a comparison. I mean, ye kadvi baatein hain, unfortunately, but just two cities if you compare, New Delhi and Islamabad. So when the COVID pandemic hit, Serum Institute of India is the largest vaccine producer in the world. It has revenues of almost $1 billion. But within 6 weeks of the pandemic starting, the Indian government gave a $610 million grant to two large vaccine producers, Serum Institute and Bharat Biotech. यही पाकिस्तान में होता है, the government would have said, आप इतनी बड़ी कंपनियां आप खुद लगाएं पैसे, हम जान से क्यों पूछ रही हैं? And it wasn't the companies that asked for these resources. The government proactively supported them. In Pakistan, there is a fund that is meant to support research and development in pharmaceuticals, but it's actually not a fund, it's a tax. It's a tax that is collected from the industry itself in the name of research. There's no transparency, so we don't know exactly how much has accumulated in that fund, but it's somewhere between 5 to 7 billion rupees. And none of it has been utilized to support research and development. It's sitting in an account in the Ministry of Finance. If you remember, there was a Delta surge in India during the COVID pandemic. And for, I think, almost 2 months, India banned the exports of vaccines and COVID therapeutics, including remdesivir, from the country to make sure that they had enough coverage for the Delta surge. Pakistan also, even though we didn't have a surge, banned our exports in that same period. The only difference was that when India banned the exports, Indian government moved in and purchased all the inventory, all the drugs produced by the manufacturers to make sure that they didn't suffer any financial losses. In Pakistan, they banned the export. There was no local requirement because we didn't see those numbers that India saw next door. But the government was not willing to purchase anything. They just told us that you cannot move this inventory from your warehouse, and much of it in the end ultimately expired. So when you have these kinds of examples, it's very difficult to dream big. It's difficult to achieve those big dreams also. So this is my last slide, because really, unfortunately, this is in the end where it lands up, is that we need a paradigm shift in thinking in Pakistan. We have the resources, we have the people, we even have the technology. What I showed you was the end stage formulation capacity in vaccines, but even moving upstream is not rocket scientists. We have some of the best minds in the world in this country, and some of them are in this room even. Together, we can achieve much more than what the government imagines. But for that to actually happen, public health needs to be an investment priority for the government. There is no country in the world that produces vaccines without buyback commitments from their governments. This is a fact. Pakistan cannot defy the law of economics. We cannot imagine a reality that does not address these fundamentals. And as I showed you, the thing to do with research is to encourage it through grants, not to tax it. When you start taxing an industry in the name of research, then you can't really expect meaningful research to take place. And ultimately, it's public-private partnerships that have taken over as the model of choice in the entire world. As I said, there is a trust deficit between the public and the private sector in Pakistan that has to be addressed. And once you have state protection for these kinds of investments, then inshallah Pakistan will flourish, and then there is no reason why in this region right next door to a country that we were a part of not too long ago, we can't achieve the same kind of miracles that they have achieved. Thank you very much.
Thank you, Dr. Usman. You have summarized, I think, this whole session in the last slide, that we need to focus on prevention, and vaccines and researchers can play a very important role in this. Now this house is open for question answer sessions. I'll ask all the distinguished speakers and the guests to please come up on stage, and so that they can take the questions. Please, sir, please आप आ जाओ stage पे question answers के लिए. Dr. Imran, Dr. Imtiaz, Dr. Naeem Majid, Mr. Usman, Dr. Shapar, our chief guest, so please, and Dr. Hiba, Madam Fawzia, please come up on stage. There are chairs here. This is fine chair for you. नहीं देखते सर एक मिनट आगे बढ़ Any question answers, please?
No, no, you're totally not wrong. I'm Hiba Heather from
Please. हाँ जी please. Students any questions? अगर नहीं तो हम लोग पूछना शुरू कर सकते हैं सवाल जवाब. I have a question about HPV vaccine, please. We have seen that we have done baseline survey here that even among doctors, HPV vaccine was extremely difficult to ask them to convince them to go there. We did a gap study last year, and the result was found that A didn't have any very good information about that. I'm talking about female doctors in the med college. And B, there were very much barriers about it. And C, what I personally felt was that people aren't willing. Even when I asked all my female friend doctors that I want to go for HPV vaccine for my daughter, they simply shied me. तुम क्यों करवा रही हो? Religion है और क्या जरूरत है चीजों की? So I want you कि अगर मुझे आपसे स्पेशल पूछना था, आपकी टॉक इस वैक्सीन के ऊपर. Have you ever thought how we are going to make it accessible? Because when I went to look for my daughter, and since Mr. Usman Wali is also here, when I went for my daughter, look for the vaccine for my daughter and searched it, it was very difficult to get. And now मुझे पता लगा कि सारा winder हो गया है, अब imported नहीं आना कोई आसान काम नहीं. So would you please both of you could shed some light over it? Thank you.
Thank you. So I will go first. So there have been various gap studies done across Pakistan on people's knowledge and perceptions on the HPV vaccine. A lot of them being medical college students as well. This vaccine is kind of slightly different from what the other vaccines that have been previously been introduced in Pakistan. They focus either on the childhood age group or within the adult age groups. It's where people have been old enough to make decisions for themselves or over the age of 18 years. So this is it does sit in a difficult place, but there have been some qualitative work also being done to elicit adolescent girls' behaviors on what their thoughts are about the introduction of this vaccine in countries. There's work done by Dr. Subhash Chandra from Indus Hospital, and so which kind of proposes a framework for introduction of HPV vaccine. So it's definitely not going to be an easy task. There has to be a lot of communication and positive communication with regards to confidence building within the medical community itself as well, and with some degree of stigma also involved around it. The vaccine that has to be so it has to be a lot of qualitative work has to feed into it before we are able to introduce this vaccine successfully in Pakistan.
So the HPV vaccine was introduced by GlaxoSmithKline in Pakistan, I think it's called so. And when it was made available, large-scale medical education programs were undertaken throughout the country. The government was engaged. But in the end, there was very little public sector interest and also public interest in acquiring the vaccine. And a big part of the inventory that came to Pakistan was, ultimately expired and unused. So that's the challenge really. And unless the public sector moves in, as Dr. Naeem, while this issue is going on about HPV vaccination, and it's likely that in 2025, again through Gavi, some procurement will take place. So vaccine will only be available regularly when there is regular procurement and there is regular use. Without the public market, it won't happen.
Once it was launched initially, we maybe it was launching with 3 doses, recommendation was 3 doses. And the cost of 1 dose was 9 and it was very difficult. It is, I think, 5 years ago, while 9,000 was a relatively large amount, it was very difficult to train. Or even parents, they used to get information, but they were scared of 927,000 rupees just for one vaccination. And then you are right that it expired. And subsequently, companies probably reducing their own profits, they reduced the cost. Probably not in the range of 5,000. But by now, the move with the initiative initially that it is a compulsory vaccine, that has gone down. Awareness, that has gone down. Probably in Punjab, even recently, the parents used to ask, okay, should you go for that vaccination? Yes, you can go, but it's very costly. Now, when the cost has come down, that move and drive, we used to ask the parents, after one,
Actually, what I said, the cost should not be consideration for the parents, for the citizens. It should really be for the government. And even with even a 9,000 rupees, I would imagine, then the cost of vaccination versus the cost of cervical cancer counter dose, there would be no. And for any rational government that is invested in healthcare, it would be a no-brainer to start a vaccination program.
Sir, but this government is not interested in the 1% or 3% experiment. But it is very dramatic to say, मैंने पाकिस्तान में जो है कहीं भी आना चर्चा करने के लिए and it is really dramatic, tragic to listen कि आप फादर को कहते हैं कि आप जाते हैं यहाँ से आप इंतजार से मंगवा लें इंतजार पे गए and he thinks for a while and say अच्छा चल leave it and I can afford the death of the child लेकिन मैं इसमें वैसे रिपोर्ट नहीं कर सकता तो वैक्सीन तो फिर उनके लिए 27 लाख unless the government supports unless the government supports.
Maybe there are 2 key indicators to assess the vaccination program in any country. One is vaccination coverage rate and the second is incidence of vaccine preventable diseases. I think Dr. Naeem and Dr. Imtiaz nicely covered the vaccination coverage rate and highlighted that among different districts of Punjab, vaccination rate has been improved like from 69 to 89%. In Lahore by e-tracking system, by using polio workers and surveillance. In pediatrician, if I see the statistics of vaccine preventable diseases like measles, tetanus, diphtheria, such cases they are being reported in tertiary hospitals. If I look at the statistics in October, we reported 8 cases of measles with complications. And in November it was 13. So day by day, in winter time, we are having increased cases of measles. So here I will advise the audience that it is just not the responsibility of government. Being doctor, it is also our responsibility when we come across any child with like diarrhea or pneumonia, we must assess the vaccination status of that child. Because as Dr. Naeem mentioned that in slums area, vaccination coverage is very low. But whenever the child gets some fever or any infection, mother brings that child to the hospital, in tertiary care hospital, we shouldn't treat just that infection. We must assess the child as a whole and then note the individual disease according to like INCI, integrated management of neonatal childhood illnesses is a strategy. If we implement that strategy, we can like promote our children development and growth as well.
I think we have another question here. Please introduce yourself and ask answer. Assalamu alaikum, respected speakers. My name is Mani Jawar Khan and I'm a final year student. Sir, my question is related to awareness of the importance of vaccination, especially among parents of children who live in far-flung areas. It's because I think they still have this hesitancy that maybe it's going to cause some side effects or it's not really important thing, or maybe if we give it, it's going to actually cause something bad to the child. We here are lucky because electronic media means are very helpful for us. I do see a lot of campaigns on the television about the importance of polio vaccination and stuff. But I don't think that this availability is this facility is present across the country, and I think there need to be something else done to increase this awareness. What are your thoughts on it? Thank you.
I think Dr. Naeem will be answering this question. And
Thank you. It is a very relevant question. And this is one of the challenge of the immunization program, that how we reach those populations. So, because we are going to have workers and some polio workers, and they are going door to door. But it is an extremely costly intervention, because if we look at the salaries of ATS workers, the government of Punjab is spending around 10 billion rupees annually, and if we look at all of Pakistan, about 25 billion rupees is spent for this salaries. And even with this much amount, the coverage is not 100%. So in Punjab, we have the highest coverage, and we have 60% rural areas covered. 40% is uncovered, so there are no health workers in those areas. So on one side, the government is thinking of expanding those workers, but on the other side, now with the rise of social media like TikTok and Snack video and other things, such software applications which are more common in the rural areas. So we are now trying to engage the influencers for that. But still, because this is a paradigm shift, this type of thinking in the government sector, public sector, it is a bit difficult to convince them that you need to engage some influencers on social media so that they can talk about vaccination. So those are some of the cost-effective strategies which the government is now planning to try out and see how message can reach out. And this was very much evident in COVID as well. As I'm sure all of us have seen that video in which someone was taking steam from the pressure cooker. So it is, that was a TikTok video, and it got circulated so much that everyone has seen it. So why our public sector or the proper right messages cannot go through the same circulation video? So this is one thing on which the government definitely needs to think and move forward on. And relying only on workers is very costly.
Yes, this is an important aspect of the teaching to every children. That is very important. The vaccine, the latency is the major cause for not vaccinating the children. So there are way outs. For example, reaching to every door, that is not possible. Secondly, yes, there are some pockets across the country which don't have access to cell phones or cell kind. But in addition to that, if you are talking about those areas, even in those areas, other than the information, the access to the challenge. So, first, in Pakistan, especially if we are talking about the Punjab, that is fine, everybody have access to that facility within a range of 5 or 6 kilometers. But if you look at the infrastructure or the ground situation of Balochistan, so if in districts there is no single functional health facility to reach out. So the primary things which needs to be done on priority in the country, that is the health infrastructure should be in place to reach out by the community to the health facility. If that is in place, so there is a snowball technique here. So if you are targeting one person, so ultimately they have a contact with another person in their family. So in that way you can get your message. The challenge this time, especially for the areas where the routine immunization is not in place or not so good, that the health infrastructure is not that much up to the mark, which need to be done there.
Dr. Nisa, would like to add something to it because you have
कि आपने कहा कि पेशेंट को हम कंट्रोल कर देते हैं तो बाद उनको भी लेकिन सऊदी अरब पेशेंट कि वहाँ पे है कि बहुत रिमोट एरिया ट्रेनिंग एरिया जहाँ पे एजुकेशन भी नहीं है तो गवर्नमेंट ने सिस्टम ऐसा किया है कि इफ एनीवन doesn't have the vaccination card, his child is not provided those basic things which are provided to the ordinary child. वहाँ गवर्नमेंट अपने बच्चों को काफ़ी सपोर्ट करती है. वो कहते हैं कि लेवल की भी होता है ना, वो कहते हैं हमारा वैक्सीनेशन कार्ड एक्टिवेट होना रजिस्ट्रेशन फॉर जब तक जाता है दिल्ली तक हुआ तो पेरेंट्स को भी आज से ही अपना पहला रजिस्ट्रेशन का प्लस आई थिंक जो स्कूल एंट्रीज हैं बाद स्कूल करते हैं इंटरेस्ट के लिए करते हैं लेकिन स्कूल एंट्रीज कैन बी रेस्ट एक बार तक वो बच्चा गोज टू द स्कूल फॉर द फर्स्ट इन्विटेशन उसकी प्राइमरी वैक्सीनेशन को चेक किया जाए और इससे एटलीस्ट चेन ऑफ मैसेज विल बी जनरेटेड कि पर्टिकुलरली नादर है बड़ा समस्या है
बिल्कुल आपने ठीक बात की और ये हम करते नहीं कि क्लास स्कूल में या पब्लिक सेक्टर में प्राइवेट सेक्टर में गवर्नमेंट ने कहा है कि आप बच्चे का एडमिशन कार्ड करना है तो कई बार लोग आते हैं कि बच्चा वैक्सीनेटेड था 4 साल हो गए कार्ड नहीं हो गया दोबारा करना है वो भी हम ला सकते हैं लेकिन ये इसको मैंडेटरी करने में जैसे नादरा में भी कोई एक और नहीं चलेगा हमारी तो बर्थ रजिस्ट्रेशन ही 100% अगर हम एक और बैरियर लगा देते हैं कि आप वैक्सीनेशन कार्ड लेकर आए तो वो बर्थ रजिस्ट्रेशन खत्म हो जाएगी यही मसला स्कूल इनरोलमेंट का है हमारे 50% बच्चे आउट हो गए अब अगर हम लोग एक और बैरियर लगा देते हैं तो वो उनके पास नया बहाना हो गया तो ये भी मतलब दोनों साइड को देखना पड़ता है तो यहाँ हमें इवन के जैसे ये बैठे हैं साहब तो जो इनकी ट्रेनिंग्स हैं यहाँ पे लाहौर में वहाँ पे उनको हमने कहा था कि आप इम्यूनाइजेशन कवरेज बढ़ाएंगे तो इन्होंने वो बैन बता दिया कि जो बच्चा इम्यूनाइजेशन कार्ड नहीं लेकर आएगा उसको हमने हेल्थ सर्विस को बड़ी सर्विस देंगे और वहाँ पे उनका हंगामा मच गया और लाइफ होना शुरू हो गई उनसे आना स्टार्ट हो गया गवर्नमेंट को हेल्थ फैसिलिटी दी है और वहाँ पे सर्विस दी है बड़ा टाइम लगा लेकिन ये कि इन्होंने बिल्कुल बैन तो नहीं किया लेकिन ये इनकरेज करना शुरू कर दिया कि नेक्स्ट टाइम आपको नहीं उससे ये हुआ कि आप काफ़ी सारे लोग कार्ड लेकर आए तो ऐसा इस तरह चीज़ें कोविड में भी हमने देखा था कि जब कोविड की वैक्सीनेशन की तो अस्पताल के गेट से अंदर जाए कोविड की पर्ची बैन कर दी थी कि जब तक आप वैक्सीन नहीं लगाएंगे तो इस तरह की चीज़ें हैं तो लेकिन वो पोलिटिकली भी थोड़ा सा चैलेंजिंग होती है कि आप ऐसी सर्विस को बंद कर देते हैं तो वो फिर उस तरह से उनके खिलाफ होते हैं स्टार्ट हो जाते हैं
तो वैसे बाद में कई लोगों को जो है मेडिकली पहले वैक्सीनेशन कराते हैं
नहीं सर देखिए सर कल की एक प्रेजेंटेशन टॉक थी डॉक्टर शहजाद बेग की किंग अवार्ड में तो वो जो बता रहे थे कि क्यों हम हर बच्चे को कोविड के अंदर नहीं पिला सकते लेट्स टेक एग्जांपल ऑफ साउथ के जहाँ पे मन्नू में 18 यूनियन काउंसिल ऐसे है जहाँ पे लोगों के वही के रीच है वहाँ जा ही नहीं सकता लेकिन वहाँ पे आप देखेंगे कम्युनिटी लेवल पर लेटेंसी नहीं है इफ यू गो टू द विलेज एवरी फैमिली इज रेडी टू वैक्सीनेट देयर चिल्ड्रन लेकिन वहाँ डिमांड बेस्ड रिफ्यूजल्स ठीक है अभी मैंने आप लोगों को ये स्लाइड दिखाया 1000 चिल्ड्रन क्या थे डिफॉल्टर्स थे फॉर वैक्सीनेशन नन ऑफ देम सरप्राइजिंग नन ऑफ देम वर रिलेक्टेड फॉर द वैक्सीनेशन लेकिन इशू क्या है जो बताई स्टूडेंट ने यहाँ पे एक तो इन्फॉर्मेशन इम्पोर्टेंस का पता नहीं है ताकि वो लोकल से जा नहीं दूसरा ये कि इंफ्रास्ट्रक्चर नहीं है फैसिलिटीज नियर बाई नहीं है तो ये कुछ चीज़ें ऐसी है कि जिसकी वजह से चीज़ों को बेहतर करने में टाइम लगता है
मैंने बस कमेंट ही करना है सारी बहुत अच्छी ये टॉपिक है जो आपने या क्वेश्चन आपने किया है आई एम कम्युनिटी पीडियाट्रिशियन इन यूएस और अब हम चैलेंज एंटी वैक्सर्स का सिर्फ पाकिस्तान में नहीं है ग्लोबली भी देख रहे हैं ड्यू टू मेनी रीजंस यू नो लेकिन नॉलेज जो होती है वो पावर होती है यही जो अपॉर्चुनिटी होती है एवरी पेरेंट की वन ऑफ यू when you graduate you should know each and every vaccine and its ingredients and what it's given for और आपको और ताकि वो सवाल करें every opportunity each opportunity should be taken up डाउट की अपॉर्चुनिटी जिसमें आप उनको रीअश्योरेंस दे सको उनको एविडेंस बेस्ड मेडिसिन दे सको बता सको कि देखो स्मॉल पॉक्स भी होता था अब नहीं होता मीजल्स के इतने ख़तरनाक तो केसेस होते थे अब नहीं होते इन्हीं वैक्सीन्स की वजह से नुकसान ठीक है दर्द होती है सूजन होती है नुकसान थोड़ा बहुत होता है कई बच्चों को सवेयर इम्यूनोलॉजिकल रिएक्शंस भी होते हैं वैक्सीन के ये नहीं कि वैक्सीन के रिएक्शंस नहीं होते हैं बिल्कुल होते हैं एडवर्स इफेक्ट्स होते हैं यूएस में भी होते हैं यहाँ पे भी होते हैं ऑल ओवर द वर्ल्ड होते हैं लेकिन उसके फ़ायदे भी बहुत ज़्यादा हैं सो रिस्क वर्सेस बेनिफिट्स बट अनलेस यू आर नॉट इक्विप्ड योरसेल्फ टू डिस्कस दीज थिंग्स और नॉन जजमेंटल वे में आपने शुरू से ही एक्यूजेटोरी नहीं हो जाना या इस पॉइंट ऑफ व्यू से कि भाई ये तो अटर जहालत की बात है वैक्सीन लेने बेस इस पे नहीं करनी बात उनको समझाने की और उन पे छोड़ देना है कतरा जो है ना बात नॉलेज बोर्ड के अंदर बैठती है देन दे बिकम दे टर्न अराउंड मैनी ऑफ देम टर्न अराउंड दूसरी बात डॉक्टर फौजिया ने बड़ी अच्छी बात की, every opportunity, US में भी यही policy है, every opportunity has to be taken up for vaccination. जब वो sick child आए तो अगर बहुत sick है, only contraindicated to get vaccine in US in the clinic is if a child has active fever. Otherwise कोई contraindication नहीं. बाकी discretion होता है clinician पे, अगर double ear infection है, pneumonia है, बहुत bad asthma attack है, you know, तो ना दो vaccine, next visit पे देगा. That's that. मेरा आपसे भी एक सवाल था, you know, आपने बहुत अच्छा, you know, that's an eye opener कि हम लोग वैक्सीन प्रोडक्शन जो है यहाँ पे नहीं कर सक रहे. मैं यूएस में इन क्लिनिक, यूएस में TVFC लाइक वैक्सीन VFC प्रोग्राम ऑल ओवर द यूएस, डिफरेंट स्टेट्स का बेसलाइनिंग की प्रोग्राम है. सो आई वुड लाइक टू नो कि पाकिस्तान की गवर्नमेंट का कोई सस्टेनेबल डेवलपमेंटल या गोल्स नहीं है रिगार्डिंग वैक्सीन्स और गिविंग अ फ्री वैक्सीन. दैट्स अ शॉकर फॉर मी, आई डिडंट नो दैट. And there is no set structure right now.
We have NIH that
Okay.
has a national mandate to produce vaccines.
Okay.
The government also.
Okay.
Sporadically वो करती भी है. But as everything else, it falls victim to politics or to sustain.
वैक्सीन उसको बनाया जा सकती है जब उसको परचेज करने के लिए गवर्नमेंट ऑर्डर. अच्छा, हमारी 99% वैक्सीन, 100% वैक्सीन है जो स्पोर्ट्स के आती हैं. Sorry, all are being exported by different international organizations. Government is not purchasing any.
That's such an idea.
अच्छा, अब उसमें ऐसा है कि अगर वो गवर्नमेंट भी बजट की एलोकेट करना पड़ेगा, उनको कोई एक चीज आ रही है तो उसका से कहते हैं इंसेंटिव नहीं है ऐसे किसी को. यस, आपके पैसे था ना कि कुछ जो वैक्सीन काफ़ी सारी कंपनियां जो बाहर से इम्पोर्ट कर रही हैं, which are becoming costly day by day. जो वैक्सीन आजकल सपोज जो हेक्सन वैक्सीन है जो गवर्नमेंट नहीं बता रही, which was probably it was just 1500 rupees, 3-4 years back it has gone to 4500 rupees. उन पे फोकस किया जा सकता है कि वो वैक्सीन की प्राइवेट सेक्टर में मांग है उसको थोड़ा सा किया जाए, so that कंपनी को बिजनेस शुरू होगा उनके इलाज करके और
Thank you so much for highlighting vaccine hesitancy. Thank you, Dr. Mahi. Now I have another question. Dr. Saro, please introduce yourself and then answer.
Assalamualaikum. My name is Adhiba. I am a student of final year. It's actually not a question. It's basically a suggestion. I'm a foreigner and Pakistan is my second home. So I have seen some changes, especially in vaccination status and the education level. I am from Sri Lanka. It is also a developing country. So the most important difference is the patients or the families coming here in the hospital. They have very lack knowledge about these vaccination and the healthcare systems. But in our country, I see that we are still poor country, but we have the knowledge. The people have the basic knowledge of all these things, and I see the reason for that is in Sri Lanka there is till 16 years of age we have compulsory free education. So in that case, even though the parents are not educated or they are from very far-flung villages who are not accessible for the other telecommunication sources, still the children, the new generation who are picking up the knowledge, they are giving the voice, the light to their family, and that is the I think that is the most strength, the strong way you can give the information to the families, because even in Pakistan there is lots of areas where there is no any mode of education and all this healthcare services. So I think it's actually it is a suggestion that if Pakistan is able to increase the literary rate, if they are able to provide necessary education up till at least 15 years of age, so that is going to provide the future generation solution, it will be the best solution for the future Pakistan. Because that, in that regard,
Thank you, Dr. Atika. You made my day the wonderful day today, because these are simply the crux of public health and simply the crux of prevention that we keep on highlighting, and hopefully somewhere in life, I don't know if Dr. Naeem is here, कि आप भी कुछ कर सकते हैं फिर इसके मामले में थोड़ा सा, because you are here the bridge, या डॉक्टर इम्तियाज आप कुछ कर सकते हैं गवर्नमेंट के साथ कोलैबोरेट करके इस बात को हाईलाइट कर दें, जनरेशन आपकी इसी तरह सेहतमंद होती है जब तक वो पढ़ी लिखी ना, the only thing which we will tell our students and which we teach and which we have felt that increasing the literacy rate is going to affect every aspect, the economic and the health aspect.
सर EPI शेड्यूल को ना निसाब का हिस्सा बना रहे हैं.
Any other question?
Smog or vaccination?
I think that is direct towards Dr. Shah, please. Vaccination and smog के साथ, especially
Smog and immunization, yeah, I think so. This yeah. And then the other thing that I'm reading lately, and I know that a lot of countries are working on it as well, is that these small smog particles actually carry bacteria, and they also carry a pool of genes. And when you inhale those, then the resident bacteria actually swap genes with the genes that you have inhaled. So it's not just increasing the rate of antimicrobial resistance, it is also diversifying the community of bacteria that is living inside your nose. So definitely, I think immunization and smog should be connected, especially for high-risk individuals.
Especially in the war.
In the war, yes. Thank you.
I think we conclude this session formally. Thank you so much, the participants, the speakers, our chief guests, and the students and our faculty members. Thank you so much, sir, for coming here. And let's conclude the session. We'll ask the guests to come to the team president. These are the